Welcome back to Plastic Surgery Untold. We have a special guest joining us today. We're going to talk about post-op scar solutions and drainless tummy tucks, which go hand in hand because that's the biggest fear for this. And so super excited to have Brandon joining us because we actually changed our entire practice of our post-op scar solutions based on a paper that you published, I think about a year ago.
Yeah, in PRS. Yeah, exactly.
Tell us a little bit about you, your practice, and so forth.
Brandon Claytor, a Philadelphia native, and returned back home about 8 years ago, took over Barry Noon's practice, and very honored to carry on his legacy at Claytor Noon Plastic Surgery. And so my Instagram page is Claytor Plastic Surgery. It's very simple. And chief of plastic surgery for the entire Mainline Health Consortium of hospitals. So that means I'm herding cats of about 35 plastic surgeons, but we all get along great. And I have a tremendous practice that is run solo practice right in Bryn Mawr, Pennsylvania, which is in the suburbs of Philadelphia.
Let's do this. Let's jump into. I know that you're a national speaker and basically international because you were actually abroad talking about this, drainless tummy tuck, which is something that's near and dear to our heart. So we'll start there and then finish up with some of your kind of groundbreaking paper that you wrote because it actually changed how a lot of people think about scar management, which is probably the biggest hindrance or drawback or thing that keeps people from moving forward with a tummy tuck.
Yeah, I totally agree. The abdominoplasty operation is a phenomenally powerful operation for men and women looking to improve that abdominal contour and, gain that aesthetic shape, that hourglass shape. Many patients will come in after their abdominoplasty and say, this changed my life. This operation changed my life. And, but the whole aspect of doing it drainless is not just one thing. It's an entire philosophy about how we come to it and how we help the patient and hold their hand through the entire process and really guide them and make them feel like they're never alone during this whole process. Even at 2 o'clock in the morning, every patient gets my phone number. And if they have a problem or a question, I share with them, please call me. I go right back to sleep. It doesn't bother me at all. But you're absolutely right. The scar can be a challenging aspect of this, and I always place it in the bikini line or underneath the belt line for a man. And if you're going around circumferentially, again, hide it so it's going to always be hidden when they're wearing clothes. But we judge ourselves, and patients look for results when they are wearing no clothes. And that's how we take our photographs of our patients and show them. They want to know what those scars look like. And we'll always take 2 sets of photographs, one with the little black underwear garment covering the scar, and then another one with the scar pulled down, or the exposing the underwear. So you can see the scar. And this can be, you're absolutely right, the make or break thing for them if they really, really love their results or if they're just kind of like, this is good. And so what I discovered years ago is that there are some patients at about a month to 4 months, they just pivot and their scars just become thick and irregular. And I was very frustrated with this. And so about 6 years ago, when microneedling exploded onto the scene and it became almost ubiquitous, but people were using it mostly on the face, I actually asked one of my estheticians to microneedle a scar that a patient had, and she was so indignant with me. She marched right into my office and opened up the packaging, and I won't say what company it was that this particular microneedling pen. But she said, see right here on the packaging, it says you're not allowed to microneedle a scar until after 1 year. And I was like, what? That is ridiculous. That, all of our basic understanding of anatomy and wound healing, I'm like, that seems crazy. So I called the company and I spoke to them and I said, look, I'm going to do a clinical trial on this. And they were like, yeah, whatever. And there was some sort of snafu, and the way that it worked out economically for me is they were able to send me the pens, the heads. But other than that, I pretty much funded the entire thing myself. And all my nursing staff, all the IRB protocols, everything. And inadvertently, I opened a window of anywhere from 6 weeks to 4 months after surgery for them to come in and start the study. I did that to make it easy for my staff and for the patients. Because, if you make a really hard, it must be at a certain time, then they're like, I'm not going to do it. And so what happened is we actually wound up having a bimodal group, a whole group of people. And then we did everything: tummy tucks, facelifts, brachioplasties, even mole excisions. We had the whole gamut.
Because those are challenging too. Thigh lifts, brachioplasties, stuff that make a big difference. And we haven't even touched on the weight loss revolution. So the amount of tummy tucks, arm lifts, thigh lifts that are coming in the next year.
It's huge. It's huge. And the scars are the number one most frustrating things for these patients. And they'll take them gladly. At the beginning, they're like, oh, it doesn't matter. I don't care about the scars. But yes, that becomes the number one biggest thing for them. And so as I opened up this study and we started to have these two groups, it turns out one group was early at 6 weeks. Another group was late at 4 months. We did 3 treatments a month apart, and then we followed them at 2 months after that. And we had all kinds of scores and grading systems to do this, and taking pictures all along the way. And it showed a statistically significant improvement in the quality of these scars with this treatment. And then what was even more amazing, as we dove deeper into the data, we found that the patients that started earlier, they even did better. It's not like they started better, but they did better ultimately. So it was hilarious, because I was in my office a couple of weeks ago, and a patient who lives in Florida who had come up, and I had treated her, and she was back in Florida, and she came back up and she said, there's this treatment now. She said, I'm working with this scar expert down in Florida, and she said to me, there's this new revolutionary technique about microneedling your scar. And she's like, you know what? I'm going to fly back to Philadelphia and talk to my doctor and see if he likes this. And she's going through this whole thing. She's like, well, what do you think of this stuff? And I said, I think it's great. I wrote it.
But you're super modest. You're not giving yourself enough credit here. But I mean, this is really revolutionary in terms of the way we think about this. Because I'll tell you, I was one of those people in the past that like, oh, let's wait, let's see how your scars do. If they don't turn out well, then we can do some of these treatments. But what you actually showed is, and it makes sense when you step back and think about it, because at 6 weeks is really kind of that peak of that scar tissue. But if you can kind of head this off at the pass, and it's what we do with everything in life, right? Don't wait till there's a problem. Let's fix it ahead of time. And that's what your paper showed. And so, but changed how most of us, and love to get Gilbert and Dr. Arredondo's thoughts, but prior to your paper, I waited to see what happened, like you said. And then when there was a problem, try to fix it. But trying to fix an old scar is very, very, very challenging.
It's impossible. So yes, I'd love to hear what your comments are.
Well, I come from a dermatology background. I just recently transitioned to plastics. So I worked with a lot of Mohs surgeons, and, scarring was always a concern for those patients. And the understanding, as you all have alluded to, is that you really didn't touch the scars for quite a while. And so we had to rely on other modalities like, silicone-based gels and sunscreen and things of that nature, massage and
compression.
As well as we had some laser modalities that we could use, but this is just, like Dr. Franco said, not to beat a dead horse, but revolutionary. It's just really, really impressive.
I'll tell you guys a funny story. So I was doing redoing, because I'm now a board examiner, so I had to get everything into the board and update everything, and they said, well, have you had any recent publications? And so I went in and was looking at my PRS publication. And I'm kind of a competitive person. And so when I looked on there, if you go onto the website, you can see there are all these numbers off to the side. And I'm looking at them and 348 and all this stuff. And one of the numbers was 99%. And I'm thinking to myself, man, I worked really hard on this paper, and I'm in the bottom 99% of all papers ever published. I'm like, this is really, And so I was looking into it a little bit deeper, and then I was like, oh,
I'm in the top.
I'm 17 out of 9,879 papers. And I was like, Who are those other 17
Hey, Brandon, before we run out of time, I want to circle back to the drainless tummy tuck and kind of why you like doing it, what made you make this change, because I'll tell you, you know, for me personally, I've loved it mostly from a mobility, getting people up and moving, because no question DVT, you know, are things that worry us with tummy tucks. No question that people who get up, moving around faster do better. And so that's the biggest reason I've incorporated it into our practice. I know Dr. Arredondo's done as well, but tell me a little bit about why you incorporate it, why you love it, and what benefit you think it has for patients.
Like most things that we do in our world, is one event that you can trace it back to that motivated you to do this. And for me, I was in practice for my first 5 years, used drains like we were all trained how to do. And I had a patient walked through a doorway with her little drain hanging out, and it wrapped around the doorknob, and it pulled out the drain. And she grabbed the drain and shoved it back in again. And of course she got a raging, and don't worry, everything turned out fine, but it was very frustrating. And I thought to myself, wow, there has got to be a better way. And as it turns out, there is. And Osvaldo Saldana, I don't know if you're aware of him, he really pioneered and popularized this idea. And so I started trying this and found out very quickly, with a few small modifications, saving scarpus fascia. I'm giving away all my secrets, so this is good. But I'm constant. I've been teaching this at this course here for 12 years, and so a lot of people have come and listened to this. So
not just this course. I mean, you
internationally.
You were
Yeah,
too.
I was just over in Florence at the Italian plastic surgery meeting, just teaching this. But so it's a very simple 3-step process that anyone could do. And so number one is I tumesce very heavily, like 4 liters in every single abdominoplasty I do. And then the dissection, I do the I just take out the flap right away. We've all done this so many times. I don't need to, cut at the bottom and work my way up. So I just take the whole thing out. But when I take it out with a scalpel, and I have an assistant sitting there cauterizing one little blood vessel as it comes along, right? So number one, I dramatically reduce the amount of thermal insult that is happening, because when you use the coag, it's actually called fulguration, and it's 2,000 degrees Fahrenheit. It's incredibly hot. So if you ever burned your finger, you would develop a little blister. So if you're not creating a 3rd-degree burn in there, you don't have that fluid to pull out. So that's number one. Number two, I spare scarpus fascia out on the lateral flanks. And Peter Rubin did a great study showing that scarpus fascia has about 20% of all the lymphatic channels in your abdominal wall. So we've all been ripping this out for no particular reason, right? Because when scarpus is thinner than that piece of paper in front of you, it has no thickness whatsoever. So you take the fat out below it, subscarpus fascia, subscarpa fat, and then the prescarpa fat, and so there's no thickness. And then the next thing that I do is progressive tension sutures, which I think is no secret. The Pollocks introduced us to this, and honestly, if you're not doing that today, I don't know what you're doing when it comes to abdominoplasty. So it's really the 3 techniques of cutting down and minimizing the thermal insult, progressive tension sutures, and sparing scarpus fascia. But then you're absolutely right. It's the early mobilization. We have a very close follow-up protocol with them where they use a protocol. I don't want to say what system, but we have a home system where they can photograph and send in pictures that are HIPAA compliant. They go directly into our EMR system. And it's incredible. It's so fantastic. And then to your point about DVTs, we could talk for 10 hours about DVTs and the importance of understanding and protecting these patients, because I love the Caprini scale. I use the Caprini scale, but the Caprini scale is completely worthless in terms of predicting whether or not your patient is going to have a DVT or even a PE. So my protocol is pre-op heparin, perioperative serial compression devices. Post-op, I give them. I don't even ask them to buy it. I just give it to them. I'm like, this is so important to you. It's going to be something I'm going to give to you. Home battery operated. So they're walking around with these leg serial compression devices, and then everybody gets Lovenox for a week. And if they have a high Caprini score, then they're going to get Lovenox for a month.
I'm so glad to hear you say that, because we actually do that in our practice too. Send them home with a compression device, and glad to know that we're not the only ones that are being maybe overly paranoid.
You're
but
not.
I feel like you just can't put a price on patient safety.
No, one of the things that I think we do too, which is a little bit of pain control related to the early mobilization, which is critical in preventing those DVTs, is I think you do a tap block, I do a tap block on everybody. that gets an abdominoplasty with expert.
And again, what's a tap block? I'm not entirely sure. You know, I know the anatomy, and I don't know if you use an ultrasound or whatever, but I will talk with the anesthesiologist, and I will ask them to give me the maximum safe amount of ropivacaine or Marcaine, and they're like, "What are you asking me that for?" I'm like, "Because I'm going to give them 80 cc's of 0.25%, Marcaine," and they're like, "That's a lot. Why do you give that much?" I'm like, "Because." I studied with Susan McKinnon, coming out of my residency. And if you block that P receptor, if you block that pain receptor right from the beginning, they're never uncomfortable. And then you're absolutely right. They're less likely splinting. I also give I give it to them incentive spirometers.
Oh, really?
Oh, and when we call them, we're like, "Are you using it?" Because let me say that, probably the number one complication concern that comes up post-op day 2, they're like, "Oh, I'm really short of breath. Oh my God, I'm terrified about a PE," right? So we have them come to the office, we check them. Ever since we gave them incentive spirometers, that's gone away because they're not short of breath anymore because everybody gets atelectasis. You got this binder on them, and the husbands are always cranking it on. That's the other thing that I do is I mark how tight I put the binder on in the operating room, and I instruct the husband, put it back on exactly like this. No tighter, no looser. And because when I didn't do this, you know what would happen? It was either always too loose, or the husband or the caregiver was like, "Well, we want it tight."
It becomes a girdle. Yeah.
And then they're going to necrose your umbilicus. They're going to and
ill-fitting garments. Nothing hurts you more than the looks great at the table, and then all of a sudden you sabotage yourself, and it's so hard to fix when it was such a little issue, and people don't think how much damage they can do if they're not fitting well.
Well, there's that great there's a good paper that came out in ASJ. I think Adam sent it to us. I think it was ASJ, but it talked about compression, over tight compression, showing an actual increase in circumference and waist circumference size relative to non-compressed patients.
100%, because I'm always explaining this to patients about lymphatics. The lymphatic system operates at 1 to 2 millimeters of mercury. You can collapse those very easily, and you're 100% right. I'm getting to the point in my career where by the time I retire, I'm going to be closing the wounds with a 6.0 fast gut, absorbable suture, and I'm not going to be putting on an abdominal binder.
It's funny, this trend, but we're running short on time, but I wanted to thank you for taking time out of your busy schedule, because I know you got a bunch of talks, panels all day long, so getting up super early to spend time with us. And thank you again, and I know our patients thank you, because it's literally changed our practice and how we've done it. So we've incorporated something called post-op scar solutions directly from your paper. So thank you so much for getting up and joining us on plastic surgery.
It's an honor. I look forward to coming back and talking about more topics.
Awesome.
Absolutely.
We'll see you soon.
Thank you.